Just a small introduction. Dr. Paolo Tarantino, he is a breast medical oncologist from Italy, but he is currently doing a clinical research fellowship at Dana-Farber under the guidance of one of the most prominent breast oncologists, Dr. Sarah Tolani.
Thank you for having me, Jason.
Trastuzumab deruxtecan and HER2. What an amazing drug. And you know, it's so funny. I was talking to one of my patients one day, telling them that this drug is so big and so important that there is a new era now. There is the era of after T-Dxd and the era before T-Dxd.
I think like we are aligned for sure about this, and I will add there's also in my personal and professional life a pre and post T-Dxd era, because I think what really made me jump into this ADC field, made me interested about all this, was seeing some of the first responses with T-Dxd in DESTINY-Breast01, the phase 2 trial in HER2-positive breast cancer. So we had it open in Milan, Italy, when I was still there in training, and I was lucky enough to get assigned to it, you know, oversee it, to follow every patient on it. And I was so surprised and positively surprised that every patient with highly pretreated HER2-positive metastatic breast cancer, patients for which basically nothing really worked that well, every patient would respond, and not respond for a little while. Patients would respond for 1 year, 1.5 years, 2 years, and that was like remarkable, and that made me think something is happening here, and I need to study what's happening. I need to be there.
Talk to me a little bit about the DESTINY-Breast03.
So yeah, DESTINY-Breast03 was this phase 3 trial that compared T-Dxd to the prior second-line treatment in HER2-positive metastatic breast cancer, that was T-DM1. And T-DM1 was is still an amazing drug, I feel, because it's usually very well tolerated. It's an infusion you give every 3 weeks, and for about 30% of the patients it works pretty well as a nice response rate. But in truth, T-Dxd was supposed to be the better T-DM1. Compared to T-DM1, T-Dxd has got a higher drug-to-antibody ratio, so 8 molecules of chemo per each trastuzumab, and a cleavable linker that leads to a bystander effect. And so on the paper, it was supposed to be better. I don't think we were expecting it to be so much better. And so in terms of progression-free survival, T-Dxd has 4-fold improvement in progression-free survival. T-DM1 was associated with about 7-month PFS, which is what you would expect in this second-line HER2-positive metastatic breast cancer. T-Dxd at 29 months, more than 2 years on a median. And so like, that kind of changed practice on the exact moment where Javier Cortez presented it. And many felt like that would have deserved a standing ovation, but it was during COVID. So it was presented half virtually, and so they had to wait a little bit. We had to wait a little bit more before we saw a standing ovation with T-Dxd, but we ended up seeing that.
Talk to me a little bit about the DESTINY-Breast04, like the setting of trastuzumab deruxtecan. What did the study contain, and a little bit about the results.
So yeah, as you mentioned, you know, T-Dxd after DB03 and after also DB01 in the beginning was an amazing drug for a small subset of patients with breast cancer, those with HER2-positive disease. We are talking of 15% of the patients, but in truth, the number is even lowering now because we are curing them early. We got so many good drugs that we see less and less recurrence in HER2-positive metastatic breast cancer. So we have something around 10 to 15% of the patients. So the idea was like, can the benefit of this drug, this very potent drug, be observed even beyond the canonical boundaries of HER2 positivity? Not 15%, but 50%, half of all the patients. And this is basically what DESTINY-Breast04 looked for. So it basically came from a small cohort of basically 40 patients in a phase 1 trial where T-Dxd had almost 40% response rate in this HER2-low population. And nobody knew what HER2-low was because we never talked of HER2-low. We always had HER2-positive and HER2-negative. But now suddenly, this low expression of HER2, immunohistochemistry 1+ or 2+, not amplified, seemed to be actionable in a phase 1 trial. But we needed a phase 3 trial. And the phase 3 trial was DESTINY-Breast04, taking patients with mostly hormone receptor positive HER2-low metastatic breast cancer, and also a few patients with triple-negative HER2-low that had been previously treated with endocrine treatment, most of them also with CDK4/6 inhibitors, and with 1 to 2 lines of chemotherapy, a median of 1 line of chemotherapy, comparing in this second-line chemotherapy setting T-Dxd versus physician choice of chemotherapy. And the choice of chemo was all agents we give every day. Eribulin, capecitabine, vinorelbine, taxanes. And basically what was observed is that T-Dxd doubled progression-free survival. Progression-free survival was about 5 months with chemo, 10 months with T-Dxd.
Impressive.
Approaching 1 year, you can see the curves both for PFS and overall survival diverging very early. And one impressive thing of ADCs seen with T-Dxd and others is that the delta in overall survival was even more larger than the PFS one. There was a 5-month delta in PFS and a 6 months delta, more than 6 months delta in overall survival, statistically improved, showing that probably if you kill the aggressive clones early, maybe you get a sustained overall survival benefit. That is something we don't get with every drug.
I mean, for me, that was, you know, I'm still at the beginning of my career, and seeing something this powerful, it gives you hope. This HER2-low, when they first throw it to us, it came out of nowhere. We were unprepared. And it was this big thing. Is HER2-low a biomarker of response, or is HER2-low a true distinct entity in breast oncology?
So first I will go a little bit back for a little historical perspective, because there was one large phase 3 trial that not everybody is aware of that specifically enrolled patients with HER2-low breast cancer. And that was NSABP B47, which was a trial. You know, we knew that trastuzumab, blocking HER2 with an antibody, was highly effective in HER2-positive breast cancer. And so the idea was, is adjuvant trastuzumab also helpful for HER2-low breast cancer? So they ran this large 3,000 plus patient phase 3 trial, randomizing patients to adjuvant trastuzumab or adjuvant standard of care, no trastuzumab. Only HER2-low breast cancer, no benefit. You see the DFS curves, overall survival curves, overlapping. To me, that's the biggest sign that HER2-low expression is not the driver of these tumors. You know, if these tumors have got or more receptors expressed, usually those are the key driver, together with other, of course, intracellular pathways. In triple-negative disease, usually tumors are more complex, and you can see P53 that is mutated, other genes, cell cycles, but in truth, HER2-low does not seem to be a driver in these tumors. But it's definitely a target. It's there on the cell, waiting for us to have the right drug to deliver chemotherapy, utilizing it with a Trojan horse mechanism of action. So I do think that we still can learn something about all this, and we're starting to use novel techniques to dissect really those tumors that do not express HER2, which are very few, because even when you don't see it, it's usually there. You gotta be very fine in order to find those HER2-null tumors. And probably there is some slight difference there, but we're talking of things that are not actionable in the clinic, and right now I think it shouldn't be considered a distinct subtype HER2-low, especially in light of Destiny Breast 06, the latest kid on the block. Destiny Breast 04 showed that in patients with mostly or more receptor-positive disease that have progressed on chemotherapy, T-Dxd is better than further chemotherapy. So the question is, what if I take T-Dxd earlier? So I take a population of patients with or more receptor-positive metastatic breast cancer, all of which have already been treated with endocrine treatment, most of them also CDK4/6 inhibitors, and I test as first cytotoxic treatment T-Dxd compared with chemotherapy. In this case, the chemos that we use most oftenly, capecitabine or a taxane.
But capecitabine was the most common one used.
Of course, which is what we do in clinical practice. Usually capecitabine is what we use right after endocrine treatment because it's an oral treatment, it works well, it doesn't come with much alopecia. But the idea was like, can we test something that may be more potent, more effective than capecitabine in the first line, or taxanes? And beyond that, there was kind of this bold attempt. Like, besides treating patients with hormone receptor positive HER2-low breast cancer, can we also test this exploratory 150 patient cohort with this new thing of HER2 ultra-low breast cancer? So what do we mean with ultra-low? We mean HER2-0, what has been always considered to be HER2-0, where the pathologist is still able to find on the slide at least 1% of HER2 staining. And it sounds confusing, but in truth, we're realizing that, you know, with trastuzumab, with other anti-HER2 drugs, we never cared about HER2-0 versus 1+. It was the same, it was negative. But with these drugs, we need to become finer. And so even within the 0, you can find some HER2 expressing tumors. And so those tumors that are called 0 but still have got some HER2 staining on the slide detected by a pathologist, between 1 and 10% of the cells showing HER2 expression, now we call them HER2 ultra-low. And last year we did this kind of experiment of putting together many different minds of oncologists, pathologists from around the world, trying to figure out these questions. Should we call this new entity HER2 ultra-low or just lump it in with HER2-low, etc.? There was so much discussion, but in the end it feels like for the moment it could be considered different in terms as a target, not as a biologic subtype, but as a target, a different and like targetable subtype that we call ultra-low. But things may change. Things change all the time. For the moment, what ended up becoming the ESMO consensus statements published last year on Annals of Oncology recommend to add this, let's say, intermediate level of HER2 expression. And so now we have HER2 positive, 3+ or 2+ amplified, HER2-low, there is 2+ non-amplified and 1+. Then we have ultra-low, there is 0 with some expression. And then we have HER2 null, where there is 0, but where the pathologist can see nothing, just blue, no pink. There is no HER2 on this HER2 slide.
I'm from the school of thought, I love basketball. If I have LeBron James on my team, I'm not gonna make LeBron James sit on the bench and play my fringe player first and then bring him in the fourth quarter to win the game. We're not gonna win the game like this. Fighting cancer is you are in a battle. You wanna be victorious from the beginning. I want to use my best agents from the beginning. What do you say to that?
Well, I will say, I will put myself in the shoes of the trainer of the team that has a long season in front of him with many games. And so I think the best part of DESTINY-Breast06 is that it allows us to tailor treatments more than we used to before. Like you know that breast cancer is heterogeneous. Metastatic breast cancer is heterogeneous in the clinical course. And we always look at these guidelines that basically are not heterogeneous, are homogeneous, are always the same. You do first CDKs and then try another line and then chemotherapy. In truth, now after DB06, we know that among these patients, if we are concerned that they are having a bad progression of disease, they have an aggressive tumor, T-Dxd works much better than chemotherapy. It clearly outperforms chemotherapy. And so if you're concerned that the patient may not get to the next line of treatment, T-Dxd is the best treatment that you can give to that patient to rescue and to ensure that the patient has got the best outcomes. Then on the other side, you have some patients in which instead you may want to wait before you use your best cards just because the disease seems to be indolent. Maybe it's bone only. Most of the patients in DESTINY-Breast06 had visceral metastases. There were only 3% with bone only disease. So for those patients with very indolent disease, maybe capecitabine, that is oral without alopecia, can still be thought of, knowing that you're going to use T-Dxd right after, because it still remains the best drug that we have. And so I think now I consider this as an option for tailoring my treatment choices. As you said, like if the patient is experiencing a rapid progression, a visual progression, symptoms from the disease, we know that T-Dxd is the best drug you can use after endocrine treatment. If the patient instead has got a very long time on the prior treatment, has got indolent disease, maybe just a new bone metastasis, maybe I can try to wait a little bit. And in truth, I think we are still talking about this because we don't have yet overall survival data that is mature. Probably mature overall survival data may change all this, and we may start using T-Dxd even for those patients with more indolent disease.
All right, so we're gonna move on now back to the HER2 positive space, all right? And first we're gonna talk about something that's very important for all of us. So in HER2 positive, as you all may know, about 50% of the patient at some times in their disease course will suffer from brain mets. It's because HER2 positive disease has a propensity to go to the brain. And initially, there was big push in the community from key opinion leaders about the HER2 climb regimen, which is the tucatinib, trastuzumab, in combination with capecitabine, because the study included a patient with active brain mets, and it showed that the drug is active in those patients. The idea was, in the second line, if patients have brain mets, to go to the HER2 climb regimen, and if there is no brain mets, to go to the T-Dxd regimen. But then there was an opportunity here for T-Dxd to look at those patients with active brain mets, because honestly, a lot of people were using it, and there was a lot of case reports being put on that it's very active in the brain, and even with patients with leptomeningeal disease. So I'm very happy that they did it with the DESTINY-Breast12. They looked at patients with the active brain mets. Talk to me a little bit more about the study. a little bit about the design, what phase, what the study was, and a little bit about the results.
So I said this was DESTINY-Breast12, a phase 3-4 trial. It was after approval to try to expand the data we have in certain important populations of patients. And so it included about 250 patients with HER2-positive metastatic breast cancer and brain metastases, including both those that we consider stable, meaning that they have been pretreated with radiation treatment or surgery or something else, and they're not active, or instead active progressing, brain metastases that either were just diagnosed or that previously treated but progressed. And so that population of active brain mets, we're talking of a very important unmet need. All of them are unmet needs, but like inactive brain mets, they're usually excluded from the trials. Instead here, they are enriched. And then we have also 250 patients without brain mets to kind of try to understand with or without this important feature of brain mets, what is the efficacy of T-Dxd. And basically, I think that the big takeaway message is that T-Dxd works amazingly in HER2-positive metastatic breast cancer inside and outside of the brain, like both in the body metastases and in the intra-CNS metastases. We saw about 70% objective response rate and intracranial response rate in these patients, which was remarkable. The PFS and intracranial PFS were beyond 1 year, were up to 17 months.
Fantastic.
And it was very interesting to see that the overall survival in the cohort of patients with or without brain metastases was basically the same.
Yes.
Was like the curves were the same.
Yes.
Basically showing that if you use a highly potent drug that works inside and outside of the brain, you can basically revert the adverse prognostic effect of brain metastases. Of course, these are the first presentation of the data. We need to follow this data to see how it evolves. But I think like it's striking and really kind of closed, let's say, this question of what should we use in second line for patients with HER2-positive metastatic breast cancer.
So that's the question. That's the question. For me, that was enough. That was the data I wanted to solidify that regardless of brain mass or no brain mass, T-Dxd is my second line. My third line will be the HER2 regimen. How about you? Do you still see that there is a space of doing the TTC regimen before doing T-Dxd, or for you also that solidified T-Dxd as your second line choice?
I personally don't. If you think of it, we have T-Dxd with 70% intracranial response rate, a PFS that exceeds 1 year, studying a large population of patients, and it's 1 injection every 3 weeks. And on the other side, you have 3 drugs, an injection plus 2 oral drugs that have got a median PFS of 8 months and a response rate of 40% intracranial. So I think T-Dxd is just like, we shouldn't do this, but we do it for the benefit of patients to compare trials. And they're not identical.
Nope.
The TTC regimen was a randomized trial that tested this hypothesis, but with T-Dxd, we got so much data now telling us that it works in the brain that I think for the wide majority of the patient, if not all, T-Dxd is my second line choice, irrespective of brain metastasis. Probably the main category of patients where I may have concerns is those with lung comorbidities. Because one thing that was observed in the DESTINY-Breast12 is that the rate of ILD was a little higher compared to DESTINY-Breast03. And also there were several fatal cases of ILD, about 2%, basically telling us that this population of patients with brain mets is probably a more vulnerable population. They are under steroids to reduce the edema. And so it's important to remember that some of these patients may be at risk for ILD, and probably I may use something different first. But we're talking of a minority. The wide majority, I think, second-line T-Dxd emerges as really reinforced as a treatment in the algorithm.
Amazing. We are agreeing. I love it. I love when we agree. All right, so let me give you one of the scenario that's not uncommon that we're gonna be facing now that we're gonna use T-Dxd with patients with brain mets. A lot of time, you wanna start this therapy right away because it's very effective, but at the same time, your radiation oncology colleagues, and I'm sure everybody faces it, wants to also radiate. What would you tell them? Can they do it concurrently, or should they do the radiation first, then start the ADC? Or if they start the ADC, take a break and then resume later? What would you tell them, and why?
So that's a great question that is emerging more and more. And in truth, we don't know if we know that T-Dxd works amazingly with or without active brain mets, with active and stable. And so we could theoretically just give T-Dxd and delay radiation treatment. in truth, we don't have great data. We don't know what's best to do. And I still like the idea of making sure that the brain metastases are treated with radiation treatment. And so, as you posed the question, should we do it together? Well, there is some real-world data actually emerging suggesting that it may be not the best idea. It may be better to wait, to do radiation treatment, and then after a few weeks start T-Dxd, at least 3 weeks. And mostly there was this JAMA Oncology paper from the MSK group, real-world data, which in the past used to be a bad word, real-world data. Now it's getting better. Now everybody's getting better at collecting it, and it seemed to suggest that there was triple the risk of radiation necrosis if you did ADCs, T-Dxd, T-DM1, trastuzumab govitecan, together with intracranial radiation. I have to say, I've seen abstracts at conferences this year that suggest the opposite. So we don't have a great answer for this. But when you're in doubt, these patients have got a long life in front of them thanks to these great drugs. And so I want to make sure that the patient doesn't have radiation necrosis. If I can wait a few weeks, I do first radiation and then start T-Dxd.
We're anticipating a lot of excellent stuff coming next year. So the first study we're gonna try to talk about, again, we don't have results. We're just gonna be talking and hypothetical. But the Destiny Breast 09, which is gonna be challenging the decade-long first-line therapy, the Cleopatra regimen of taxane plus dual HER2 blockade, trastuzumab and pertuzumab. Here, the study has 3 arms. One arm is with T-Dxd alone. The second arm is still with T-Dxd plus pertuzumab, and the third arm is the Cleopatra regimen. Now, very interesting thing is that the Cleopatra regimen, you do the chemotherapy only for a short period of time, and then you continue with the maintenance that doesn't have chemo, only HER2-directed therapy. Whereas the 2 other arms with T-Dxd keeps on going. We don't stop. We don't know the results. We're anticipating it's going to be a positive study because we know T-Dxd is more powerful than chemotherapy. What do you think about the study design? About this one of them you stop short, whereas the other one you continue? And even if it's positive, do you think that people are going to adopt it? Or do you think they're going to wait for it to be used in the second line?
So let's first say, I think it's going to be positive.
Yes.
Just because, as you said, T-Dxd works better than chemo, especially T-Dxd indefinitely compared to chemo for a short time. And I will say the Cleopatra regimen is kind of an anomaly in breast oncology, because usually we do not stop drugs if they're working. And I think this is something that we need to do, because taxanes are amazing drug that they work very well, but have this issue that after a while they cause unbearable peripheral neuropathy, and so you have to stop. It's not a choice. T-Dxd doesn't have this. You have patients that can get it for years and keep benefiting from it without having more side effects. And so I think potentially the fact that you can give it indefinitely is a pro, because if you can keep the tumor under the pressure of chemo while maintaining a good quality of life for a long time, it's a good thing. That said, we know that some patients may not need that, because some patients, you can give this intensive chemo for a while and then they can remain on HER2 blockade for years without progression. The issue is recognizing those patients, and right now we don't do that. We use Cleopatra with the maintenance HP for all of them because it's what we have. So I think in the future what's going to happen is that if the trial is positive, and I think it's going to be positive.
I think so too.
One of the 2 arms. I think the pertuzumab will add something, especially later on, not in the first phase, but later. Physicians will figure out how to maybe reduce the dose, and then at a certain point, maybe after many months or maybe years, stop it at certain points. So I think it's going to become very artisanal, just because you cannot replicate exactly what the trial did with the reduction criteria of the dose according to the trial. I think we're just going to be doctors. We're going to figure out how to best use the drug, and for patients that seem to need more, I've got maybe very aggressive disease that doesn't respond perfectly, maybe you keep the patient on for a longer time. But if the patient after 6 months or 8 months or 1 year has got a complete response of disease and has got some side effects, well, maybe you start reducing the dose, and if it's not enough, maybe you even stop it. So I think we're getting there, but what we really need is a biomarker telling us that, and we don't have that yet.
Thank you. And that's why oncology is still an art. That's why you're irreplaceable. AI will not replace you. Remember that. But you're totally right. We need a biomarker. We need something to let us know, am I going to be okay just doing the Cleopatra regimen, or should I go more aggressive and using T-Dxd? Or even better, is that a biomarker that tells me I'm okay to give a holiday from T-Dxd, because the chance of ILD doesn't stop early on. It's not front-loaded. It doesn't, ILD, the risk of ILD is sustained the more you give it. It's not gonna stop. Like if your patient did not get ILD in the first 8 or 9 cycles, doesn't mean they're never gonna get it. There is always a risk of ILD. And that's something that worries me, because let's say your patient got a complete response, yet you keep on going, and then they got this ILD, that's it. This drug is gone. It's gone from your arsenal. So in the future, if you need it, you cannot use it. But how about if you got a CR, like you said, maybe you can switch to something else. It maintains HP at that time. And in the future, in case the cancer came back, they can reintroduce T-Dxd and restore disease control. What do you think about that?
Well, I think that I'm very glad that there is a trial already start enrolling that is looking at this, the METER trial, that basically gives induction T-Dxd for, I believe, 6 to 8 cycles, and then starts maintenance HP subcutaneously. And I think it's going to be an important trial. It's a single-arm phase 2 trial, so it's not a randomized. It's not going to give us perfect evidence, but at least
some evidence.
It's some evidence. And then what they do is that if the patient progresses, the physician has the option to reintroduce T-Dxd. And I love the idea, because if you can use this highly active drug for a while, and then you stop, and then if needed, you use it again, and then stop. Maybe in this way, we can limit the resistance acquisition from the tumor. Not that we're sure, maybe we're doing the opposite, but this trial is gonna test that, and I think it's gonna, both DESTINY-Breast09 and the METER will give us a way to utilize T-Dxd earlier in patients that may derive some benefit from it, and maybe cure more patients. I feel this is an important thing in HER2-positive metastatic breast cancer. Sometimes we see super prolonged disease control for 8 years or 10 years or more. Some patients seem cured. Can we increase the number of those patients?
Here you go. You heard it first here. Curing metastatic breast cancer. We are getting close. Love it. Love it. Love using that word. All right. Anytime you have such a powerful drug, you always want to bring it to the early stage. Why wait for the cancer to become metastatic? So here we're going to talk about 2 other exciting studies, the DESTINY-Breast05 and the DESTINY-Breast11, that are in early stage HER2-positive breast cancer. Talk to me about them.
So yeah, like as you mentioned, like this drug works amazingly in a metastatic setting, but what about using it where we can actually prevent recurrence, cure patients, and try to erase these micrometastatic clones before they get to become metastases? And so DESTINY-Breast11 is the neoadjuvant trial of T-Dxd that has 3 arms. Traditional chemotherapy with anthracyclines times 4 followed by THP, which I have to say I don't love.
I don't love it.
I don't love. I don't usually like anthracyclines in the early setting, but I realize that many groups do still use anthracyclines.
I think the debate that was at San Antonio put the nail into the coffin. TCHP is the way to go.
Right. But the trial needed also an international regime in Europe. Many centers use more anthracyclines. And so AC times 4 followed by THP compared to 8 cycles of T-Dxd or to T-Dxd followed by THP. And the thing I like the most is actually replacing anthracyclines. And so either with 8 cycles of T-Dxd, but even just with 4 cycles and then THP, if we could do that, it's a great achievement. And then what else? Well, I have to say, DESTINY-Breast5 even more. Because, we're realizing that we can understand what is the risk of recurrence by looking at response at surgery after neoadjuvant treatment. And so DESTINY-Breast05 builds on the foundation of Catherine, comparing adjuvant T-Dxd versus T-DM1 among patients with residual disease at surgery after chemo and HER2 blockade. And so I like both trials, but I think DB06 really tackles these high-risk patients that did not achieve complete response, trying to escalate, to erase the clones that may have led to resistance there. And so I expect in some different way both trials to be positive, but I think they may impact let's say, the way we use the drug in different ways. And personally, I really, really like the design of this DESTINY-Breast5. I really look forward having an option to prevent recurrence in this population of patients that have HER2-positive breast cancer that usually is considered treatment sensitive, but it actually is not, because you find residual disease. And so we need to have some powerful drug. We know that T-DM1 improves overall survival in this population, but still there are many patients recurring and dying, about a quarter of them. Can we avoid recurrence in this quarter of patients not being cured? I think we can. I think DB05 will be positive and will show that we can prevent recurrence.
What do you tell people like myself that are worried about the ILD?
First of all, I say thank you for remembering about this important thing, because like everybody should, whenever using T-Dxd, should know about ILD and should think about scanning the patients, doing all the 5 S's. So that's fundamental. Then I would say look at DESTINY-Breast3. Look at those curves. Look at what happens when you use a drug like T-Dxd compared to T-DM1. And so you can really change the life of this patient if you cure, prevent that recurrence. Hopefully, we still don't have the data, of course.
Yes.
And so I will say definitely scan the patient frequently, like it's done in the trial.
Yes,
Make sure to remember that, because like we cannot, usually the severe ILD that we see are because most of the times you start to have some ILD low grade, even grade 2 with some symptoms, but it's thought to be something else, so you keep going with the drug. We don't want that. We want that whenever the patient has got some cough, has got some shortness of breath, some change in symptoms, and or there is some spot on the CT scan, you always remember ILD. And you always remember that you gotta stop the drug and make sure to exclude or understand if it is ILD, treat it with steroids. So important to be aware of that, important to treat it and diagnose it and treat it early, but also important to remember of DB03, that if you use T-Dxd compared to T-DM1 in the right moment, you can change the trajectory of disease.
You can, for sure. I agree. So remember that, because we're not used to scanning in the adjuvant setting. But here we're gonna have to scan, at least for that year.
And one thing I will say that will emerge, and we don't have great answer about this thing that will happen, the more you scan, the more you find, of
100%.
course. And so many patients will be found to have some suspicious lymph node somewhere, something that is unclear if it's a bone metastasis or a bone island, all these things. And we're gonna need to deal with this. We're gonna need to understand, can this patient be cured despite having this finding somewhere outside of the breast? And it's gonna become an important question, research question, and also clinical question that we need to think about. My idea is, yes, if you have a good enough drug, even patients that have got this suspicious intrathoracic lymph node or this bone metastasis somewhere can be cured, but we don't have a great answer. What about you? What do you think?
Yeah, no, definitely. I'm super excited. You know, when you have powerful drugs, you want to use them, but you have to use them in a safe manner, right? We know what to expect. We know the side effect. We know how to catch it early by scanning frequently, by having a low threshold to stopping the drug and doing the appropriate workup to make sure that there is nothing going on, to continue that important therapy and not lose it. I think we're getting a lot better. We have gotten a lot better at catching it early. Our pulmonologists also are much more familiar with that drug, and they know when to call it and when not to call it, and so forth. So I think it's very important to do it, to give it, especially if it's going to improve outcomes, reduce the risk of recurrence in the brain and elsewhere, but do it safely. That's the key point. Always do no harm before benefiting your patients.